is the RNA string of the virus, the genome of the virus. We break open the virus shell, we take out the RNA, and then we multiply that RNA many times until we can see how much virus, that the virus is there and how much virus there is there. So that's what RT-PCR really is. If you look at the rapid tests that are being described, what the rapid tests are measuring is not related to the RNA of the virus, not the genome of the virus. That is detecting when a person gets infected, the first thing that you see is the outside of the virus, the proteins that make up the virus ball-like structure. We call it coronavirus because it's a ball with spikes on it. So the first things we will see will be the spikes and the outside of the ball. Now, when the body sees that, the body reacts to that and makes antibodies, which are intended to control the virus. And the rapid tests are detecting the presence of those antibodies. So if you look at the two components of tests, the RT-PCR is looking at the genome of the virus. What is inside the virus, we break it open and we multiply it many times. In the other test, we are looking at the body's reaction to the proteins of the virus. And for that reaction to happen, it takes some time. So when the virus is in your body, in your nose, in your throat, if you do a nasal swab, you will be able to find the virus, because if it's there, we will be able to find even tiny amounts of the virus because we are looking for the genome. When you need to find whether the body has made antibodies, that means that the virus has to get inside, it goes inside cells, those cells get infected, the body recognizes that there is an infection and then makes that antibody response. So the rapid tests cannot be used when the person has just gotten an infection or has just started to have symptoms. The rapid test can only be used 1 week after the person becomes symptomatic. So if you want a strategy that allows you to identify people who are infected quickly, you can't use the rapid test. You have to use the RT-PCR test. If the purpose of testing is isolation, there is no choice but the RT-PCR test. But if you want to find out that in our entire population of 60,000 people in Kalimpong, has anybody ever been infected? You know, we didn't know that they got infected. They had a fever 3 months ago. It didn't come to our attention. They had a cough or they had no symptoms at all. Then if you want to know whether a person got infected or not, what you would do is take a small blood sample, not a nasopharyngeal swab. You take a small blood sample and test in that blood sample for the presence of antibodies. So the uses of the two tests are very different. RT-PCR for making a decision on isolation and the rapid test for understanding how much infection there has been in the population. I hope that's helpful, and if you have any questions about that, please ask me.
Thank you so much for making it so simple and understandable for the common person. Anybody else wants to pipe in with some questions?
Good morning, ma'am. I'm Vivek from Darjeeling. Hello, can you hear me?
Yeah, we
Vivek,
can.
I can hear you.
Ma'am, like this particular pandemic, which is COVID, a droplet infection, right?
Yes.
So we've also 20 feet, distance of 27 feet and onwards. So, ma'am, I just wanted to relate this question with what are the findings right now? And because I want to relate this question with the wearing of the mask, ma'am, there's a lot of confusion on what kind of mask we should be wearing and all that. So could you clarify this a bit, ma'am?
Absolutely. So the main way that this virus spreads is by droplet infection. And when we talk, when we sing, when we cough, when we sneeze, you've seen for some people more than others, you can actually see what comes out of their mouth. Whenever we are doing activities with our throat that results in a sound, or we are expelling something through a cough or a sneeze, we are actually putting out whatever is in our mouth and nose. And that can be of different sizes. Sometimes you see with people, they spray saliva when they talk. That is visible, but there are also a lot of invisible things that come out of our mouth. And these can be large droplets or they can be small droplets. They can also be something that is called aerosols. All of the spread of the virus is airborne in a sense because it's either droplets or aerosols. So what happens when you have a big droplet? A big droplet is heavier. It will fall to the ground faster. If you have small droplets or aerosols, they will float around for a longer period of time. So if you look at the aerosols that this particular virus is found in, it's mostly found in large droplets. And these large droplets fall to the ground faster. That means, so this instructions that we are given about distancing take into account the distance to which these large droplets can go before falling to the ground. It's estimated to be about 3 feet for large droplets. So that's why 3 to 6 feet is the distance that people are saying. You should be beyond that to prevent the bulk of infections. But in some cases and in some studies, it's been shown that there is also a component of smaller particles, smaller droplets, not between 5 and 10 microns, but between 0 and 5 microns as well. Now, because these particles are lighter, they can float around a lot longer. Many of these smaller particles are generated during certain procedures and mainly in hospitals. So if you have to be intubated, if there is a suction, then you get what are called aerosol generating procedures that make these smaller particles. Now, when we have these droplets, which I said 3 feet, 6 feet away, which is the main mode of spread, they land on surfaces. So whether it is your table or your phone or, door handles, you can also acquire infection through touching these objects. So ways of getting infection, if you are near somebody who is infected, who is talking, sneezing, coughing, you might get infected. If you touch objects that are contaminated with droplets that somebody else has left behind, you might get infected, but that is a smaller proportion of infection. And then if you're in a hospital where aerosol generating procedures have been done, you might acquire infection from there. And that's one of the reasons doctors and nurses are infected much more than other people. Their kinds of exposure are much greater than in a normal population. So now coming to what masks do. Will a mask prevent you from acquiring infection? What are the various ways in which you can get an infection in your nose and throat? You can get it from the mouth, you can get it from the nose, you can get it from the eyes. The eyes actually have the tear gland duct can be connected to areas in the nose as well. So the 3 kind of doorways to infection with this is your mouth, your nose, your eyes. Right? So if you want to prevent infecting yourself, wearing a mask stops direct access to your nose and your mouth. And the kind of mask that you use determines how much you can prevent from getting across. So when you have a cloth mask, what should you do? When you have a surgical mask, what should you do? When you have N95 or respirator masks, it's called N95 because it removes 95% of the particles in the air. You have other kinds of masks that are labeled like that. So for cloth masks, very important to remember that you should not, over time, your mask will become humid because you have water in your throat. So when your mask becomes wet, that's the time for you to, wet or damp, you should be thinking about removing that mask and replacing it with another mask. This is important because a warm, damp environment is one where survival of viruses can be promoted. So for cloth masks, important things, keep your mask clean, dry it in the sun, don't use the mask without washing it and drying it really well. You might want to iron the mask. And when you are wearing a mask, whether it is a cloth mask or a surgical mask, don't touch the front of the mask, because touching the front of the mask can lead to viruses getting in and can potentially contaminate your hands. When you think of surgical masks, the things to remember are the things that I said about cloth masks, but use the strings of the mask or the elastic of the mask to handle the mask. Don't touch the front of the mask, and if you're taking it off for some time and intend to reuse it, fold the mask with the front surface inside and only use the elastic or the strings of the mask to touch it. Okay, surgical masks should not be reused for more than a day. Cloth masks you can clean and reuse. When it comes to N95 masks, one, because there is a shortage, N95 masks should be, as far as possible, provided to healthcare workers and not the normal population. But you follow the same criteria of not touching the front of the mask and making sure that you're only using the handles of the mask rather than touching the surfaces of the mask. N95 masks can be reused with sterilization. These can be reused up to 3 times with sterilization, but the sterilization is with UV light, with hydrogen peroxide, etc., which is a bit difficult to do in a home environment. Now, this is the use of masks for people who are well, who want to prevent themselves from getting infected. But you also need to think about the use of masks for people who are sick. For people who are sick, it is absolutely essential that they wear a mask, because their wearing of the mask will contain the infection as far as possible inside the mask. So for them, you should be trying to provide a mask that they can use effectively, preferably a disposable mask like a surgical or an N95 mask. And the idea here is, after that, you should dispose of that mask because it is a source of infection. You should dispose of the mask as you would dispose of for any infectious waste. And that means either giving it to a hospital for disposal or looking at whether you can put it in a bag and burn the mask. So this leads to some environmental contamination, but you really don't need to, you don't want these masks lying around where people can touch them, because that might be a source of infection. So I hope that answers your queries about masks. I would be happy to explain anything about this.
Right, thank you, ma'am. Anybody else? Otherwise, I've got a question. Yeah, Vivek.
Can I just come in one?
Yeah.
Ma'am, I was just like going through with the print recently, and you said that for 80% of the population is just going to be a bad flu kind of a thing, like the entire thing.
That's
so,
right.
Do you think like we should go, and there's this talk about this herd immunity coming into play. So is that true? Like the herd immunity can help us? And the other part of the question is that if it's just the 80% who's going to have a very mild symptom, like a bad flu kind of a thing, then is it okay for us to, get ourselves exposed to it? Like, I guess some countries like Sweden are, trying to do it. So, would you suggest that also?
So this is a very important question, and I mentioned early on that this is, until you have the infection, you're not going to acquire antibodies to the immune. With most viral infections except HIV, when you make an antibody response, you have a reasonable level of protection against that virus, at least for all the respiratory viruses that we know, like influenza, for example. If you've had one kind of flu, then you have some protection for some time against that kind of flu. So it's likely that with this infection also, people who have had infections will be protected from infection for some time. We hope it will be a long time, but we don't know how long. So the idea of herd immunity or herd protection is that when 100% of the population has never seen a disease before, and this disease is one where one person can give it to 2 or 3 more people, the disease can grow very quickly. One person gives it to 2 people give it to 4 people give it to 8. It multiplies very rapidly in the population. But if you have a population where 60% of the population has had disease, one person cannot give it to 2 people anymore, because of all the people that they see, 60% of them are already protected. So chances are that one person will be able to give it, that one person will need to meet 5 people and be able to spread it to only 2. That slows the spread of the population, spread of the infection in the population. And that's called herd protection. So a number of countries understand that if you allow your younger people to get infected, and your younger people are usually the ones spreading most of the disease because they are the ones that are going to be interacting in school, in college, at work with other people, then what will happen is over time, the levels of exposure in the population will build up and it will slow the spread of the infection in the population. This will then allow us to have a disease where we can handle it reasonably with the resources that we have. Right now, what is the problem? The problem is right now we have an exponential growth, a very rapid growth, because everybody is uninfected and nobody has protection. Once more than half of the people are infected and have some level of protection, the spread of the disease will slow down, because if half the people that you encounter are already protected, the reproductive rate of the infection slows to 1 or less than 1. Which means that this becomes a disease that is then in the population but does not have the kind of rapid growth that we are currently seeing. The problem with that approach, one is that we know that older people who get infected and people with comorbidities who get infected have a much more severe disease. So if you have exponential growth and you have severe disease in the elderly and those with comorbidities, your hospital systems will not be able to handle it and people will die because the hospitals can't handle it. surveillance. So the slowing of the spread of infection that we are doing through the lockdown now is intended for us to build capacity for doing the testing and the isolation that you can do based on the RT-PCR, but also build capacity in to be able to handle severe disease. Over time, our younger people will get infected. Over time, can you hear me?
There is a problem.
Okay, now we can hear. So over time, our young people will get infected. Much of our population will get infected. But what we are trying to do right now is to slow the spread of the infection as much as possible. If there was a way for us to do this, sensibly, if we could predict that all young people would do all right, that all young people would not have a problem if they got infected, then we would be okay. The problem is that we know that in many situations we have no way of predicting who will do well and who will do badly. When you think about infections, the infection is not the same in everybody. Some people are asymptomatic, some people have severe pneumonia, some people have neurological symptoms. There are stories now of COVID-19 disease presenting as strokes. So this is a new infection. It's an unpredictable infection. If it was a predictable infection, if we knew that everything would be limited to just people having a fever and cough and they would all get well, it would be fine. But we know that in very, very rare cases, young people can also die of this. So it's the combination of the unpredictability, the rapid growth of the infection now, the fact that our health systems need to be built up for both surveillance and care of patients, that has actually led to us coming to the situation that we are now in, of trying to put everything we can in place to make sure that disease does not spread. And that is, the lockdown being really strict. We are not 100% preventing the infection. We know that from our numbers. But we are significantly slowing the spread of infection. There is hope, of course, that soon we might have drugs or vaccines, and once we have drugs or vaccines, we have other ways of preventing or handling infection when it comes. Vaccines will prevent, drugs will at least provide some measure of treatment so that people are not so badly off even if they do get infected. Right now, we don't have those tools. So that's why we are focusing all our effort on slowing the spread of infection, preventing new people from getting infected.
Thank you, Doctor. Anybody else?
What has been the stage of the development?
Yeah, Vivek, go ahead.
Yeah, I think there are a lot of programs that were going on across the world for the vaccine, and I just read today morning that the Oxford University has also started some human trial. So what is the progress, ma'am? Any idea on that particular front?
On vaccines and drugs?
Yes, ma'am.
So let's start with drugs first. There is a global clinical trial for 4 kinds of drugs which is being run by WHO. It's called the Solidarity Study, and what they're doing is they're testing 4 approaches to drugs. 2 are drugs that are used for HIV. One is a drug that was developed for Ebola, was a failure, but it looked good for MERS. So that is being tried. And the other one is hydroxychloroquine, which is an anti-malarial that many people have thought has an antiviral action, but currently it's not used for any other viral infection. So in this solidarity trial, what they're trying to do is look at the effect of these 4 drugs on very simple outcomes. did the person who was COVID positive, who was put on any of these 4 combinations, did they get well or did they die? So it's a simple study. The hope is that it will have very large numbers of patients so that we will get a solid answer. The problem with many studies that people do is everybody has a favorite drug. Everybody has a favorite approach. So whether it is something from Ayurveda or from an antiviral or something that affects the immune system, everybody thinks that they have the answer. The problem is that if you want to get a proper answer, you need a proper study. You need to make sure that just because I'm interested in showing that this approach works, then I should not be biasing the results and doing a small study and saying that it works. So there are many ways that people do clinical trials, and what you want is a clinical trial that produces strong, robust, solid answers so that we can rely on that. If we do too many small studies, then we are actually harming our chances of getting the answers that we are looking for. We will have inadequate evidence for deciding whether something works or not. So clinical research is important. So those are 4 drugs that were available for something else and are now being tried for SARS coronavirus 2. In addition to this, there are programs that are looking at existing libraries of compounds. Many pharma companies, many research organizations study millions of chemicals that they keep in as a library. And then when you have a new disease, you can screen your library to see which compound you have that might be effective against your new target. And that is being done in many places around the world. In addition to that, there are people who are studying the viral structure and trying to design new molecules that can block certain parts of the virus that are important for the virus to get in and the virus to multiply. So there are many approaches that are being taken for preventing infection. There are also approaches that are being taken that target the host. What is it that you can improve about a process in the host or block in the host so that the virus can't replicate? All of these approaches are being taken to try and develop new drugs, to test drugs that exist, as well as develop new drugs to target this. The answers from the clinical trials like Solidarity and others, we will get those answers in a few months, and the drug discovery programs will take a bit longer than that. Usually for a molecule to go from being completely new to actually being a drug takes many years. We hope the process will be accelerated and we might have potential drugs by next year. When it comes to vaccines, again, things have never moved this fast for anything before. There are 90 plus, now over 100 plus programs that are looking at developing vaccines around the world. And what we would like to do with many of these programs is to quickly select which ones are likely to work and take them forward. 6 of the 100 plus studies have already reached human trials. But when you go into humans, the first thing that you study is safety. So the first studies are in small numbers of people looking at safety.
It's not working here. Anybody online? Shreya, are you there? Anybody there? मेरा सर्विस
So it may not be the same vaccine for everybody. There are 100 plus candidates out there, and we might have 2 or 3 successful vaccines. So which one is more suitable for a country like India? That's something we need to look at. In India itself, 5 of our vaccine companies are looking, 4 of our larger vaccine companies and 3 smaller companies that I know of are looking at making vaccines. If any of the 4 larger companies manage to make a vaccine, we know that we will have a cheap and affordable vaccine. I think it's very important that you know that actually India is one of the biggest suppliers of vaccines to the world. Indian companies make most of the childhood vaccines that are given around the world. So whether you are in South America or Africa or Asia, likelihood is that if you were in a public health program, then the vaccines that were given to children there were made in India. So we have capacity to produce lots of vaccine, but it has to be a technology that our vaccine companies are familiar with. So the fact that we have so many of our companies already engaged is good, and I don't think we will be very far behind the rest of the world in having vaccines available when they become available. The question of who gets vaccines first is going to be an important one. And I think we will probably need to order it by making sure that all healthcare workers and then all people who are extra vulnerable, the elderly, the people who have comorbid conditions, they should get the vaccine before young healthy people get the vaccine. So there will need to be some kind of prioritization, and we are already working on what that might look like.
Naren bhai, you have been working at the forefront for the Kalimpong outbreak. तपाईको के क्वेशनहरु छ भने सोध्नुस् न नरेन भाइ.
हुन्छ, मेरो छैन अहिले त.
Roshan, anybody?
Speak in English.
होइन जे भए पनि हुन्छ बुझ्छ नि Roshan, are you there? Roshan?
I already asked about the cost and of the vaccine.
Okay, I was out at that time. Dr. Kang,
Hello?
one thing is that we've seen a lot of these images of being people being tested on the roadside, in kiosks, etc. Even in place like Kerala. That is the type of is that the type of tests that are required to check the effect of the how far the penetration of the virus has gone, and why is it not being implemented elsewhere in the country?
So I think the Kerala government has had an approach to testing that has been beyond what was recommended by the central government. And they have been implementing testing quite well. So the kinds of booths that you are seeing are really around having personal protective equipment for the people who are collecting the samples and might therefore be exposed. But I think the only solution that will get us out of this, as I said at the beginning, what do you want to do? You want to slow the spread of the virus. You cannot necessarily identify all asymptomatic infections, but you can test all people with symptoms and isolate them quickly. And that must be the purpose of the testing that we do of the nasopharyngeal swabs. Right now, nasopharyngeal swabs are a little challenging because of the requirement for PPE. The swabs are in short supply. It requires RT-PCR. But there are different components of this that are being worked on. And we are thinking that we should be looking at whether it should be possible to do even self-swabbing. Could you collect a sample and send it to a central place for it to be tested and then get the results back on your phone? Many places are experimenting with these kinds of approaches, and once they have been validated, I hope it will be possible to expand the scale of the testing and then inform the public health action based on that testing.
Right, Doctor. Anybody else for any tests? Any questions? What I would like to ask you, Doctor, is that how does one deal with the problem of asymptomatic people? How do you manage that?
Unless you were testing everybody every day, you don't have a solution. So again, it's asymptomatic infections who are contacts of symptomatic cases can be identified through the strategy which currently is for any contacts to be tested between 5 and 14 days after the symptomatic case has tested positive. So if that approach is done, we will identify a proportion of asymptomatic infections. We will miss a few, but then missing those few will lead ultimately to other symptomatic cases, which again we should be able to pick up. So I don't think it's going to be possible for us, ideally people think that we should be looking at how we wipe this virus out. But it's important to remember that any virus that an asymptomatic component, we have never managed to wipe out.
It's not able to push out.
So if you look at smallpox, for example, smallpox was only transmitted when the person was symptomatic. So we were able to eradicate smallpox. But we've had a polio eradication program, and polio is another infection where asymptomatic infections happen. And so far, despite so much of effort, it still is there in certain parts of the world. So I think thinking about eradicating an infection, it's too early for that with this infection right now. But we will, currently the way it's set up, we will miss some asymptomatic cases, but we will be able to pick up those infections when they get into people and then that person has a symptomatic infection.
Right, ma'am. Now, ma'am, for Kalimpong or Darjeeling district as such, what do you suggest would be a sort of a strategy to contain this?
So I think screening symptomatic people is your best approach. There are many ways of doing it. China, for example, set up separate fever clinics. So if you have fever or you have a persistent dry cough, come into a fever clinic and get tested there. That reduces the load on the hospital. In the hospitals, we know now that there are many presentations of COVID-19 that are not the characteristic ones of fever and cough or difficulty breathing. There are people who are coming in with strokes. There are people who are coming in with symptoms that look like a heart attack that turn out to be COVID-19. So it's when these kinds of situations arise, then treating everybody as potentially COVID positive and following infection control precautions is the only way to go. It's important to remember that because this is a brand new infection which is spreading globally, we are in a situation that none of us have encountered before. With H1N1, the difference between that and now was that many people who were around in the 1950s, 1970s had encountered H1N1 before. Many people who got H1N1 got asymptomatic infections and mounted an immune response, and very rapidly it settled into being another seasonal influenza virus. So it was a pandemic. It spread around the globe, but it was a pandemic where the mortality was much lower than we are seeing with this virus. And there was some amount of pre-existing immunity in the population. In this case, we don't have the pre-existing immunity and we have the higher rate of mortality.
Right. Thank you, ma'am. Any questions? Any more questions from the panel? If there are no questions, may I wrap up this session? It's just about 1 hour, and I'm sure Dr. Kang would be busy. May I, on behalf of the entire panel...
Also, I had one.
Yeah, go ahead.
Sorry.
Go ahead.
Can I ask one quick one?
Sure.
Yeah, so if there is a mild one, what exactly would you recommend the person to do at home?
Stay hydrated, take paracetamol, take your favorite antitussive medicine. So I personally like Honitus a lot. So if I was to get it, I would take medicine and Honitus and, just stay by myself. Drink lots of water.
But when do we go to the hospital? Thank you. But when do we go to the hospital, ma'am?
You go to so basically right now, because there is a requirement for isolation, you have to notify public health authorities and see if they will allow you to stay at home if you have a mild infection, or whether they want you to come in and be isolated in the hospital. So whatever you are told to do by the public health authorities, you need to do that. But most of COVID-19 is stuff that can be handled quite easily at home. And many of the people in isolation are asymptomatic or mildly symptomatic. Every state is handling it a little bit differently in terms of who is allowed to stay home and what kind of isolation facilities they are offering. But what you want is basically hydration and management of your symptoms. The point at which, if you are allowed home isolation, any time you have difficulty breathing, you should go into a facility.
Right. Any more questions from the panel? Right, I think we can wrap it up. Dr. Gagandeep Kang, it's been an honor to be talking to you. Thank you so much for all these wonderful insights. It's been a pleasure talking to you, and I hope we can once again meet up. I hope that we won't have a recurrence of the COVID outbreak here, and that we can talk in better times. Thank you so much, Dr. Kang. Thank you again, Anu, for arranging this. It has been a wonderful eye-opening session. Thank you so much.